Good morning, everyone, and thank you very much for joining today's webinar about the new EQ-5D-5L value set. This is an important methods update for NICE, and a public consultation on the case for adopting the new value set is currently live and will be open until 5 p.m. on the 27th of May. But in the next hour, my colleagues Koonal, Shah and Sophie will talk you through what the value set is, how it was developed, how it could change NICE's recommendations, and how we are proposing to implement it as part of our methods. We know that you might have questions about this, and there should be plenty of time for Q&A after Koonal and Sophie's presentations. You can submit your questions for us via the submit question box that you should be able to see on your screen. Finally, before I hand over to Koonal, I want to acknowledge that although this is a change to NICE's methods, it is one that we anticipate will have some impact on NICE's cost effectiveness calculations, and therefore it ultimately will also impact prices of medicines. Therefore, it is part of the recently published arrangement between the United States and UK on pharmaceutical pricing. The focus of today's webinar is very much on the methodological aspects of the value set, the impact it could have on NICE decisions, and how we are proposing to implement it as part of the work that we do. But we will also cover what we know about how it might impact prices for those of you who are interested in that. And with that, I am going to hand over to Koonal. Over to you.
In my presentation, I'll explain a tool that plays a really important role in NICE decisions and how we assess healthcare treatments and interventions, the EQ-5D. So as was shown on this slide just now, NICE's purpose is to help get the best care to people fast while ensuring value for the taxpayer. And for us to know what counts as best care and what counts as good value for money, we need to understand how different interventions affect both how long people live and what their health-related quality of life is like. And the EQ-5D is key to that. So by the end of my presentation, I'll want you to understand what the EQ-5D is, why NICE uses it, how it feeds into another key tool that we use, the QALY, what a value set is and why that matters, and why NICE intends to adopt the new EQ-5D-5L value set for the UK. So let's start with the basics. The EQ-5D is a questionnaire that people fill in to describe their health. It doesn't diagnose conditions, it doesn't ask about specific conditions, but it captures how someone is functioning in everyday life. It was designed to be simple and easy to understand, designed to be short and therefore straightforward to include in clinical trials and other studies, and to be applicable across many different health conditions. And that last point is really important for us. The EQ-5D is what we call a generic measure of health. That means that the same questionnaire can be used for someone with arthritis, cancer, diabetes, heart disease, and the results can still be compared in a meaningful way. And from NICE's point of view, that comparability is crucial. So why does NICE need a questionnaire like this at all? Well, we're often asked to assess very different types of treatments. For example, a cancer drug that extends someone's life, a mental health intervention that improves daily functioning, or a treatment for migraine that reduces pain but doesn't affect survival. And to compare these different treatments fairly and consistently, we use a concept called the Quality Adjusted Life Year, or QALY. A QALY combines two things: how long someone lives and their quality of life from a health perspective. Very simply, 1 year of life in perfect health is equal to 1 QALY, and 1 year of life in less than perfect health is worth less than 1 QALY. To calculate QALYs, we need a way of turning descriptions of health or health states into numbers that reflect how good or bad those health states are. And those numbers need to be on a scale where 1 represents full health, 0 represents a health state that people consider no better than and no worse than being dead, and in some extreme cases a health state can even be considered worse than dead. And the EQ-5D is a tool that provides those health descriptions in a consistent and reliable way, supported by many decades of research and development. It's regularly used for capturing the quality of life component of the quality adjusted life year. Now, the EQ-5D is not perfect. No single measure of health is perfect, but we do prefer it and recommend it for a few reasons. First, it's generic, so it allows comparisons across different diseases and treatments. Second, it supports consistent decision making across the health and care system. If every evaluation we undertook used a different quality of life measure, then it would be really difficult to compare results and to ensure that each treatment was being assessed fairly. Having a single preferred measure helps us to make consistent decisions. And third, the EQ-5D is practical and robust for real-world use. It's widely used, it's well studied, and it's relatively easy for people to complete. And this combination of comparability, consistency, and practicality is why NICE prefers the EQ-5D when estimating quantities. Let's now look at what the EQ-5D questionnaire actually asks. The EQ-5D descriptive system covers 5 areas or dimensions of health: mobility, which is how well you can walk about; self-care, how well you can wash or dress yourself; usual activities, so this is things like work, study, housework, family and leisure activities; pain and discomfort; and anxiety and depression. Each dimension asks the person completing the questionnaire to indicate the level of problems they have in that area today. So, for example, the mobility dimension asks the person about their levels of problems walking about today. And together, the 5 answers that someone gives creates a snapshot of their health at a particular point in time. In addition to the descriptive system, the EQ-5D also includes a visual analog scale, but I'm not going to explain that today because NICE doesn't use that part of the questionnaire in its reference case. Let's make this more concrete with an example. Let's imagine there's someone called Amelia who has a chronic knee condition. Before treatment, Amelia completes the EQ-5D questionnaire and she reports having slight problems in walking about, no problems washing or dressing herself, moderate problems doing her usual activities, moderate pain or discomfort, and no anxiety or depression. Those 5 answers together describe Amelia's overall health state before treatment. Now suppose Amelia receives a new treatment and a few months later she completes the questionnaire again. And after treatment, she reports having no problems walking about, no problems washing or dressing herself, no problems doing her usual activities, slight pain or discomfort, and no anxiety or depression. So what's changed? Amelia isn't living any longer as a result of her treatment, but various aspects of her health-related quality of life have improved. And the EQ-5D captures those improvements in a structured and standardized way, and these can then be used in the economic evaluation that forms the basis of many of NICE's assessments. So far, I've talked about the EQ-5D as if it's just one tool, but in fact there are different versions. Historically, the most widely used version has been the EQ-5D-5L. So in this version, each of the dimensions has 3 levels: no problems, some problems, and extreme problems. And this made the questionnaire simple, but it also had limitations. In particular, it was often felt to be insensitive to small but important changes in health, including some of the improvements that Amelia experienced in our example. To address this, a newer 5-level version was developed, the EQ-5D-5L. So in the 5-level version, each dimension has 5 levels ranging from no problems through to extreme problems, and it gives people more options to describe their health accurately. As a result, the 5-level version is more precise, improves sensitivity, and it better reflects real changes in health. Throughout the rest of this webinar, we may use the terms EQ-5D-5L and 5L interchangeably. So far, I've talked about how people describe their health using the EQ-5D, but the descriptions alone aren't enough to calculate quantities. We also need a way of converting each description into a single number called a utility value. And that's where a value set comes in. A value set is essentially a scoring system. It takes every possible EQ-5D health state and assigns it a utility value. So as a reminder, these values are on a scale where 1 represents full health and 0 represents dead, or a health state considered no better and no worse than being dead. So for example, a health state that most people to consider to be quite mild might have a value of 0.9, and a more severe health state might have a value of 0.4. These utility values are what we use to calculate QALYs. There are 3,125 health states in total, and that reflects the total number of different ways in which someone can complete the EQ-5D-5L questionnaire. And the value set gives a utility value for each and every one of these 3,125 health states. It's important to note that each value set is specific to a particular country. And this is because utility values are based on people's preferences or how good or bad people consider different health states to be. Those preferences can vary between countries, and that may be due to differences in cultural norms and expectations about health and illness. And for NICE, whose remit is to provide guidance for England and whose guidance is often adopted by other UK nations, it's important that these values reflect the preferences of the UK population. And when I say the population, I mean the general population. So it's not just patients currently experiencing a condition. This is a deliberate choice, and there's several reasons for this. And the most important one is that because NICE is making decisions on behalf of everyone, it needs values that reflect society as a whole. Our job is not to decide what is best for any individual patient, but it's to make recommendations about how NHS resources should be used on behalf of everyone. And everyone includes people currently receiving care, people who may receive care in the future, and people whose care may be displaced in order to fund new treatments. It's really important that all of these people are represented in how health benefits are valued. To calculate utility values and produce a value set, researchers study what the general public thinks about different health states. This is done through what's called a valuation study, where members of the public are asked to express their preferences using structured tasks. There's several different methods for doing this, but the new UK EQ-5D-5L value set used a method called the time trade-off, or TTO. For anyone interested in the methodological detail, the UK valuation study is reported in a free-to-access scientific article. What I'll try to do now is give a simple explanation of the time trade-off method, as it's central to the new study. So although the name of the method sounds technical, the idea behind the time trade-off is quite intuitive. So study participants are asked to imagine living in a particular health state for a certain amount of time, in this case 10 years, and then they're asked how many years in full health they would consider to be equivalent to that. So for example, would you prefer living for 10 years being unable to wash or dress yourself and having severe problems doing your usual activities, or a shorter time in full health? And by adjusting the amount of time in full health until the participant feels that the two options are equally desirable, researchers can work out the value they place on the health state. And when this is done across many people and many health states, they then have the data that they need to produce a complete value set for each and every possible health state. At the moment, NICE typically uses a UK value set for the 3-level version, the EQ-5D-3L for its QALY calculations. That value set is based on a study that was conducted in the 1990s, and it was robust for its time, but had some clear limitations. It reflects the preferences of the population from over 30 years ago. It doesn't reflect current UK demographics and societal preferences, and it was developed using older methods for obtaining and analysing preferences about health. Since then, both UK society and health economics have moved on. And what's also moved on is the way in which we measure health. So the 5-level version of the EQ-5D, it's a clear improvement over the 3-level version. NICE has been recommending its use for several years. In the absence of an accepted 5L value set, any data collected using the 5L questionnaire needs to be mapped onto the 3L value set to calculate utility values. This has been sufficient as an interim solution, but it's an indirect approach and therefore has limitations. There are several reasons why adopting a new EQ-5D-5L value set for the UK makes sense. First, the methods for understanding preferences have improved. We now have better designed studies, clearer tasks, and more sophisticated modelling techniques. The new value set was developed using state-of-the-art methods, developed over many, many years of piloting and learning from the experiences of other countries. Second, the EQ-5D-5L value set, the EQ-5D-5L instrument itself is preferable to the 3-level version. Most notably, the fact that it has more levels means that it's more sensitive and can better capture small but meaningful changes in health. And third, using a 5L value set allows us to avoid mapping or converting 5L data back into 3L values, which introduces additional uncertainty. In very simple terms, our preferred approach is to collect data using the 5L questionnaire and value it directly using a 5L value set. And the publication of the new UK value set for the 5L allows us to do that. As I mentioned earlier, the value set and the methods used to produce it are reported in a free-to-access scientific article. If you are interested in the detail, this is an excellent paper to read. At a very high level, the value set is based on the preferences of a large representative UK sample of 1,200 adults from across England, Wales, Scotland, and Northern Ireland. Rather than using a self-complete online survey, preferences were collected through interviews to ensure high data quality for these really complex tasks. The interviews were carried out by highly qualified interviewers who undertook dedicated training and assessments, and they followed a standardized protocol. And all of the research followed internationally recognized best practice for EQ-5D valuation. There were rigorous data quality checks and oversight from a steering group, which included academic experts and representatives from NICE, as well as NHS England and the Department of Health and Social Care. In terms of what it shows, as with the old 3L value set, pain and discomfort came out as the single most important dimension, meaning that problems with pain and discomfort tend to have the biggest impact on overall quality of life scores. And in contrast with the 3L value set, anxiety and depression and usual activities now carry more weight than before, while mobility and self-care contribute slightly less on average. I'm only really able to scratch the surface in this webinar, but the paper by Donna Rowan and colleagues sets out the evidence in full and is well worth reading if you'd like to understand more about these values and how they were calculated. It's important for me to say what adopting the new value set does and does not mean. It does not change the overall system NICE uses to assess treatments. NICE will still ask for EQ-5D data, still calculate QALYs, and still use cost-effectiveness analysis to make judgments about whether interventions offer value for money for the NHS in the same way. What changes is the quality of the data going into that system. The new value set provides utility values that better reflect current UK societal preferences, are based on more sensitive health descriptions, and make QALY estimates more accurate. So rather than replacing the system NICE uses, the new value set strengthens it. To sum up, the EQ-5D is a simple, powerful way of describing health that underpins how NICE measures health-related quality of life in our economic evaluations. And value sets convert descriptions of health into numbers that reflect what matters to people. Adopting the new EQ-5D-5L value set is necessary to keep NICE's methods up to date, robust, and reflective of what matters most to society today. That concludes my presentation. My colleague Sophie will pick it up from here.
Thanks. So in my presentation, I will be explaining the work we've done to prepare for adopting the 5L value set and understand the potential implications for NICE's guidance. This work included considering whether the change might have any negative impacts, and in particular we focused on people with protected characteristics or those affected by other determinants of poor health, and whether they could be affected more than other groups. So in other words, we considered the impact on equality and health inequality. I will also be covering the proposed changes to our manuals, our timelines for implementing the methods change, how you can get involved in the consultation, and what resources are available to help you respond to the consultation and also prepare for the change. So whilst we're confident that adopting the 5L value set is the right thing to do to improve the accuracy of our assessments, it's also really important for us to understand the potential impact of this change on our future guidance and recommendations. So we commissioned an academic group at the University of Sheffield to conduct some impact assessments. Our consultation materials explain the results of these assessments and also provide links to the full reports published by the researchers at Sheffield but I'll summarise them for you today. So the first activity was to look at how the incremental cost effectiveness ratios, known as ICERs, change when we switch from the 3L value set to the 5L value set. And I'll be using that abbreviation ICER for the rest of the presentation. And first I'll explain what ICERs are and how NICE uses them. So we assess whether a treatment provides value for money for the NHS by looking at the benefits the treatment provides compared with what's currently available, and how much more it costs compared with what's available. And as Koonal already described, we measure benefits in two ways, by looking at how long someone lives and looking at their health-related quality of life. And we combine these two things into a single unit called Quality Adjusted Life Year, or QALY. And the ICER tells us how much money the new treatment will cost to gain one extra QALY, as shown by the equation pictured on the slide. And after a recent change to our methods, technologies associated with an ICER less than £25,000 to £35,000 per QALY gained are usually considered a good use of NHS resources. In their impact assessment, the researchers at the University of Sheffield looked at 37 published NICE technology appraisals as case studies, which were selected because they broadly reflect the range of disease areas considered by NICE. Now, within those 37 case studies, there were actually 39 ICERs to look at, because in some technology appraisals, it's relevant to look at how well the intervention works in different subgroups of people with a condition, and for the committee to make different recommendations for those subgroups. The researchers then replaced the utility values in the economic model for each appraisal, which had been generated using the 3L value set, with utility values generated by the new 5L value set. And they did this using a technique called mapping. They then looked at how the switch from the 3L to the 5L value set affected the QALYs gained with the new treatment and the resulting ICERs. So the results in a nutshell were that the 5L value set made some medicines more cost effective and some less cost effective. And that depended on whether the health benefits of the medicine were driven by improving a person's health-related quality of life or by helping to extend how long they live. So when comparing the new 5L value set with the old 3L value set, we're seeing that people are now less willing to give up years of their life to avoid being in poor health. And this suggests that people now place more weight on length of life than on health-related quality of life, compared with what we saw in the 3L value set, which was conducted over 30 years ago. So among other things, it's the balance between the impact on length of life and quality of life, which determines if any individual medicine or technology will be more or less cost effective when using the 5R value set. But the findings from comparing the two value sets reflect more than just updated societal preferences, as Koonal alluded to earlier. They also reflect changes in the measure, so moving from the 3-level version to the 5-level version of the EQ-5D questionnaire, and also improvements in the methods for studying people's preferences and for modelling that data. What this means in practice is that all of the cancer medicines included in the impact assessment, and most of the medicines that help to extend how long people with non-cancer conditions live, became more cost effective. So the ICERs reduced in the case studies in the impact assessment. And the medicines that did not affect how long people with non-cancer conditions live became less cost effective. So the ICERs increased in the impact assessment. It is important to note at this point, these results are based on a small sample, and it's not possible to fully predict what the effect the 5L value set will have on all future evaluations. But our consultation document provides some advice on how to interpret the results. The second activity was looking at whether the 5L value set impacted how often NICE committees would apply what's known as the severity modifier. So for anyone not familiar with NICE's severity modifier, it allows committees to give extra weight to the health benefits of a treatment when it is used for a particularly severe condition. The way we define whether a condition is severe is by looking at whether it will cause a large loss in a person's future QALYs compared with the future QALYs for someone in the general population without the condition. So it's not about just whether a condition shortens someone's life expectancy, but also takes into account how much the condition compromises their quality of life in their remaining years of life. This loss in QALYs may be measured as either total QALYs lost, known as absolute shortfall, or AS for short, or as a proportion of the QALYs the person would be expected to experience if they didn't have the condition. That's known as proportional shortfall, or PS for short. And depending on how severe the condition is, the QALYs gained from the new treatment are multiplied by either 1.2 or 1.7, as shown in the table here. So in other words, we're putting more weight, more value on the benefits of the treatment if it's for a severe condition. And by doing this, we increase the number of QALYs associated with that treatment, which in turn reduces the ISA. So it makes the treatment more cost effective and means we can recommend more expensive treatments if they provide substantial benefits for people with severe conditions. The reason the new value set impacts the application of the severity modifier is that to calculate QALY shortfall, you first need to calculate the quality adjusted life expectancy for the general population. And this needs two things. First, we need an estimate of the life expectancy within the general population, which changes depending on age and sex. And second, a weight to be applied to each year of expected life based on the quality of life of the general population, which again differs by age and sex. The new 5L value set is required for calculating that second part, applying a weight to each year of expected life to understand the general population's utility values by age and sex. So on to the impact assessment. The researchers at Sheffield used the same 39 technology appraisal recommendations, ISAs, used in the impact assessment I've already described, as well as 18 additional recommendations that reflected more severe conditions or that were close to the cut-offs for qualifying for the severity modifier. And the analysis showed that moving from the 3L to the 5L value set is unlikely to change the severity weighting in most technology appraisal decisions. And the explanation for this and more details from the analysis are provided in the consultation document and the published report from the University of Sheffield. So what our impact assessments have shown us is that some people could potentially be negatively impacted by NICE adopting the 5L value set. This includes people with certain chronic and disabling conditions where the aim of treatment is to improve quality of life rather than to help extend how long a patient lives. Because the impact assessment showed that treatments for these conditions may become less cost effective than under NICE's current approach of using the 3L value set. And we recognise that people will be worried about this. But we believe there won't be a significant negative impact on our recommendations or patient access to treatments that improve quality of life rather than help extend how long a person lives. And this is based on confidential commercial data that we hold within NICE about medicine pricing and about the relationship between medicines prices and ISAs. That being said, a step we can take to mitigate against the potentially negative impact of adopting the 5L value set is to promote existing flexibilities in our methods. So, although, as Koonal described earlier, NICE prefers all evaluations to use the EQ-5D to calculate utilities, our methods do permit the submission of evidence from other health-related quality of life measures. And this is because we recognise that in some circumstances, the EQ-5D may not be the most appropriate measure for capturing health-related quality of life. This includes, for example, when evidence generation is difficult, for example, for rare diseases, or the nature of the condition means the EQ-5D doesn't work very well. It should be clear that the negative impact of the 5L value set on the ISA for a particular treatment would not be an appropriate justification to submit data from another health-related quality of life measure. What we would need to see in order to accept data from another measure is explained in our current manual. But to summarise for you today, we would ideally need to see systematically gathered evidence that the EQ-5D does not adequately reflect people's lived experience of their condition. And there are several elements to this. So first, we ask for evidence that the questionnaire does not include all the important aspects of quality of life that are affected by a condition and that matter to people with condition. Second, we ask for evidence that the questionnaire scores don't properly reflect people's health and the severity of their condition. So in other words, although someone might have poor quality of life, this isn't properly reflected by the responses they give on the EQ-5D, and people with very different levels of illness can end up with similar scores, suggesting the measure doesn't distinguish well between them. Third, we ask for evidence that the EQ-5D does not reliably detect meaningful changes in a person's quality of life over time, so as their condition progresses or as their condition responds to treatment. Our manuals acknowledge it might not be possible to generate all of this evidence, in particular in rare diseases, so committees do have flexibility to consider other types of evidence to show that the EQ-5D is not appropriate. But to reiterate what I said before, that the negative impact of the value set on the ISA for a particular treatment wouldn't be an appropriate justification to submit data from another health-related quality of life measure. When the time comes for us to implement the 5L value set into our methods, we will be providing NICE committees and staff and our external academic groups with briefing materials and training that explain the impact of adopting the value set, drawing attention to the populations that could potentially be negatively affected and the related equality and health inequality issues, and that promote awareness of these existing flexibilities in our methods. And if you'd like to understand more about the potential impact of the value set on equality and health inequality, there is a specific document in the consultation materials which provides the details of how we approached our assessment as well as our conclusions. Ultimately, we feel that adopting the new value set is necessary to keep NICE's methods up to date, robust and reflective of what matters most to society today. We're confident that the new value set provides utility values that better reflect current UK societal preferences, are based on more sensitive health descriptions, and make QALY estimates more accurate. And more accurate measurements mean better and fairer decisions. And better decisions mean patients get access to treatments that truly matter. The consultation materials provide the full details of which sections of the manuals will change and our proposed wording. But to summarise our recommendations for you today, we propose the manuals require updating to stipulate that utility values should be calculated using the EQ-5D-5L descriptive system and the newly published value set. The manuals will also state that data gathered using the 3L descriptive system should be mapped onto the 5L value set using the mapping methods recommended in the current technology appraisal manual. We, as I said, recognise that data from the EQ-5D is not always available or appropriate, and our current manuals present a hierarchy of our preferred approaches for measuring health-related quality of life in the absence of EQ-5D data. And our consultation materials include the proposed updates to this hierarchy in light of the 5L now being our preferred measure. The updates will affect the wording in two of our manuals. Firstly, the NICE Technology Appraisal and Highly Specialised Technologies Guidance Manual, and also the Developing NICE Guidelines Manual. The 5L descriptive system and value set will also be required for any health tech evaluations that require calculating utility values. However, the health tech programme manual doesn't require any updates because it doesn't mention the EQ-5D measure. It actually directs readers to the Technology Appraisal and Highly Specialised Technologies Guidance Manual for information on measuring and valuing health effects. So, on to my final two slides. We encourage patients, health and care practitioners, industry representatives, researchers, and other stakeholders to share their views on adopting the 5L value set via our consultation. We've extended the deadline by 2 weeks, so it's now open until 5 p.m. on Wednesday, the 27th of May. We'll then consider all of the consultation comments before finalising our implementation plans, and we'll publish a summary of the feedback received, as well as our response to that feedback and how we'll act on it. The nature of the consultation feedback and any actions we need to take will influence our timelines for implementing the new value set. So it's difficult to anticipate exactly when we'll publish our updated manuals, but we're aiming to do so over the summer. And importantly, we'll have a programme of dissemination and training for our external stakeholders, including industry and voluntary and sector organisations, and for NICE staff and committees and the internal external assessment groups that critique the evidence submissions from industry or develop models for guideline production. And I mentioned some of the key content for this training earlier. In line with our published framework for updating our methods, the 5L value set will be prospectively applied to NICE guidance. So what I mean by this is that it will be used for topics where the evaluation starts after publication of the updated manuals. So for technology appraisals and highly specialised technologies guidance, this refers to the invitation to participate. And for health tech evaluations, this refers to topic launch. And for NICE guidelines, this refers to topic selection. It's also important to note that we will not routinely be re-evaluating technologies that were originally assessed using the 3L value set. NICE guidance will only be considered for updates if there are changes to the evidence base, clinical pathway or economic case that are likely to have a material effect on the recommendations. Some of you may be aware, and Jacoline alluded to it in her introduction, that our plan to adopt this value set was announced in December last year, at the same time that government announced its decision to increase the thresholds that NICE uses in technology appraisals. And that's part of the deal between the United States and the United Kingdom. I just wanted to make it clear that the timelines for these two changes are different, as is the approach to implementing them. So unlike the threshold change, which applies only to medicines, the 5L value set will apply to all of our guidance that involves calculating utility values. The new thresholds applied from the 31st of March, and they can be applied to ongoing technology appraisals. Whereas, as I've just described, our adoption of the 5L value set will not be fully implemented until later this year and will not apply to ongoing appraisals. And as the final slide before Q&A, I wanted to let everyone know or remind you that you can find much more detail, as we've suggested, on what this change means to NICE in the consultation documents and in the supporting resources that we've signposted in those documents. And those supporting resources are listed on the slide here. They include the peer-reviewed journal publication of the 5L value set, which Koonal mentioned is free to access, and also the option to request the data used to develop the value set from Eurocol's website. Also reports and the journal publications from the University of Sheffield with the full details of their impact assessments. NICE's Decision Support Unit, also based at the University of Sheffield, have updated their technical support documents, or TSDs, that are affected by this change, and updated the software that the organisations who submit cost effectiveness analyses to NICE might need. Firstly, there's some guidance for what to do if you have data from the 3L questionnaire and need to map it onto the 5L value set to produce utility values. There's an updated technical support document to help with this, TSD 22, and the Decision Support Unit have also incorporated the new 5L value set into their mapping model and published the updated software commands. All of these are linked and signposted in the consultation document. Secondly, there's guidance and tools on how to calculate the QALY shortfalls associated with a condition that determine whether a product qualifies for the severity modifier that I described earlier. There's an updated technical support document again, this is TSD 23, and updated software that supports the calculation of QALY shortfalls, which we refer to as the shortfall calculators. These resources are all for information only, to support your understanding and to enable you to carry out your own impact assessments. So we're not inviting comments on the content of the supporting resources. The QR code on the screen will take you to the consultation page. And as I said, you'll find links to all of the documents listed on the slide there, and they're within what's called the evidence review document. So with that, I will hand back to Jacoline to chair the Q&A.
Great, thanks very much, Koonal and Sophie, for your presentations. So we have a number of questions that already have been submitted, but please, if you have any other questions, feel very free to also send them our way, and we will do our best to answer as many of them as we can in the next 20 minutes. So Koonal, I think the first question I think is for you. So the question is, were patients and the public involved in developing the EQ-5D or the 5L value set to know what impacts are most important? Also, there is a lack of a measure for social inclusion or loneliness, which has a huge impact on health and well-being.
Yes, so the EQ-5D and the 5-level version in particular is supported by a large body of evidence. So patients and the public were involved in its development, but also in the psychometric testing of the instrument. So things like testing its validity or whether the questionnaire measures what it's intended to measure. And some of that evidence is from the UK, and there's also a lot of evidence from elsewhere. So these studies of psychometric properties were undertaken on a very wide variety of people with many different kinds of health conditions. The fact that the EQ-5D includes only 5 dimensions means that it's inevitable that it won't capture every aspect of health-related quality of life. There is no single questionnaire that is fully comprehensive. But having only 5 dimensions is also a strength, so it keeps the questionnaire short, simple, and easy to include in studies. NICE recognises that the EQ-5D may not always be the most appropriate questionnaire in all circumstances, and for that reason, we do publish in our manuals, alternative approaches that can be used if it is not possible or inappropriate to collect EQ-5D data.
Thanks very much. Sophie, I'm going to ask you the next question that we've had through, which is, with the introduction of the new 5L value set, how is NICE thinking about encouraging greater use of the 5L instrument in clinical trials by sponsors, particularly given evidence that its use remains relatively low in regulatory submissions compared to HTA contexts?
Great question, and an interesting one, given NICE have supported the use of the 5L instrument for a long time. So our current methods manual expresses our support for that instrument as a more sensitive tool. And I think, as the person notes, its submissions to NICE, it's quite prevalent in submissions to NICE. So for a long time, we've seen evidence submitted using the 5L questionnaire. It's just that it's had to be mapped to the 3L value set that we've been using. So absolutely, we'll continue to support use of the 5L questionnaire in trials and promote it. We can use, the routes that we have and the sort of advice mechanisms that we have through our NICE advice service and other services where we engage with companies, with sponsors, with other parts of the healthcare system to promote that.
Great, thank you. Next question, Koonal, I hope that you can answer, which is, until newer crosswalks or more country-specific tariffs are available, should sponsors rely on the UK value set only, or stick to the old versions of the same for the specific country? And I think this question really is about, what should sponsors do in situations where they have measured EQ-5D, 5L, perhaps in different countries, such as in an international trial?
Okay, so because NICE is UK and the remit is for the UK, our recommendation is that when the new UK value set should be relied on. Even if for any submissions to NICE.
Great, Thank you. So another question, Sophie, that I hope you can answer. If a patient cannot complete the questionnaire, can a carer or a family member do it on their behalf?
Yes, there are provisions for proxy, what we call proxy reporting, to complete on the patient's behalf, and in particular conditions or circumstances where that's relevant.
Great, thank you. Koonal, next question for you. And my screen has just moved. Give me 1 second. How do you deal with rare or ultra-rare diseases? As in this case, could we use data which has been used across different countries due to the rarity?
Yeah, we recognise that data collection and evidence generation can be really challenging for rare and ultra rare diseases. And as I mentioned in the previous answer, our methods do and continue to provide some flexibility. So the manual shows what other approaches can be used if it's not possible or appropriate to use the EQ-5D. What I would say is that our first preference is to have data collected from people in the UK because that's most relevant to the NICE context. If it is necessary to use data from other countries, we would still recommend the use of the UK value set study because those are the preferences that are relevant in NICE's context.
Thank you. The next question is for Sophie. How will NICE introduce this value set, and what implementation challenges are NICE expecting with the new value set? For example, if 5L values are not available for comparator medicines.
Really good question, and there will be, and there is already often uncertainty, even about. You may have a published utility value that you've taken from the literature, and uncertainty about whether it was collected using the 3L or the 5L instrument or value set, and then there may be more explicit examples as this person has raised around. Actually, you know that 5L values aren't available, and what we try to do in the hierarchy of evidence that we include in the manual and the guidance around that is to plan for those eventualities and to give guidance on those sort of different circumstances and what the order of preference is to what you would do in those circumstances. So hopefully questions such as that specific one and other issues around absence of data, absence of the preferred data should be addressed in our manual, but it's really helpful to get those questions through now in the webinar. We will keep track of all of those and we can make sure they are addressed in the updated manual. Also, they can be, of course, submitted at consultation, which will be really helpful to make sure we've covered all eventualities. The first part of the question around sort of how we will implement and challenges. So as I've described, we'll, the implementation timeline and nature of that will really depend on the nature of the consultation response and whether we receive anything unexpected that we haven't prepared for. And as with all methods changes, there are challenges with changing what we know and changing behaviour and getting access to different data. So as I mentioned before, we have a great NICE advice service. We have lots of channels to make sure that any uncertainty in evidence generation and evidence submissions and planning for submissions can be addressed and concerns reduced in the lead up to this. So we'll use all of those channels and, as I said, hopefully preempt a lot of those questions in the manuals itself.
Great, thank you. Next question for you, Koonal. Do you have any examples of disease areas where EQ-5D is not the best way to collect health-related quality of life data? You have mentioned rare diseases, but do you have any additional examples of those types of disease areas where it might not be the best instrument?
Yeah, good question. I mean, for the majority of conditions that NICE looks at, particularly in our technology appraisals program, EQ-5D has been shown to work pretty well. But there are some areas where it's got known limitations, and some of the examples are around like sensory issues. So conditions affecting someone's eyesight or hearing, EQ5D doesn't contain dimensions specific to those, so it doesn't work particularly well on those conditions. Likewise, conditions affecting people's cognition and understanding. So in those cases, an alternative way of capturing quality of life may be appropriate.
Great, thank you. Koonal, a second question that I think you're probably well placed to answer, which is why is the value set rooted in public preferences rather than considering preferences of patients or those with lived experience? Should we not consider experienced health state valuation above hypothetical?
Yeah, this is a long-standing area of debate in the health economics and health technology assessment academic literature. So I've mentioned some of the reasons why we rely on population preferences, and that relates to what NICE's purpose is, which is to make decisions on behalf of everyone. So not just people who are experiencing a health condition today, but also people who may experience a condition tomorrow, and further into the future, and also all of the other people that the NHS serves whose care and future care may be displaced by spending more money on a new intervention for a very specific treatment. And that principle is really important to the way that NICE works. The sample of the public that was used for this valuation study includes many people who are current patients, and it contains people with a wide variety of different current health statuses. So I think the approach that NICE uses in focusing on population preferences is consistent with many other countries using a similar approach to conducting health technology assessment. So we're aware of sort of the arguments for and against, but overall we feel that this approach fits best with what NICE is trying to achieve.
Great, thank you so much for explaining that. Sophie, we've had a couple of questions about the use of the value set in children. So one I would like your thoughts on is the 5L value set was collected in adults. What do we do for children's health-related quality of life?
Really, really good question, and one that has been the subject of a lot of discussion and research within and outside NICE for many years. You're quite right that the 5L value set was collected in adults, and the EQ-5D-5L as an instrument, the one that Koonal gave us a screenshot of on his slides, as an instrument, as a questionnaire, is designed for use in adults only. There are separate versions of there is a different version of the EQ5D, the EQ5D youth version, which has been adapted and tailored to make it appropriate for using with children and young people. There isn't a value set for the youth version of the EQ5D. There is one in development, and Koonal can perhaps come in and talk a little bit about that if it's interesting for people. But because there is no value set for the youth version of the EQ5D, and because there are lots of different generic measures that can be used in children and young people, some of which do have value sets, some of which don't, NICE hasn't been able to recommend a specific measure or value set to use in children and young people. So our methods, our manuals are explicit that we don't have a preferred method there, unlike many of the other things we talk about in our reference case. We don't have a preference in children. So we give some guidance in the manuals around selection of an appropriate instrument. For example, a measure, we still prefer a generic measure. So as Koonal described in his presentation a measure that allows us to compare treatments and have consistency regardless of the population and the condition, rather than a disease-specific measure. And one that's been shown to have good, what we call psychometric performance. And what we mean by psychometric performance are those aspects I described earlier when I said, if you wanted to make a case that the EQ-5D wasn't appropriate in adults, we'd need to see evidence of X, Y, Z. So that's collectively described as psychometric performance. There are, and then that case will go to the committee to discuss and consider. It would not be appropriate to use the adult value set in children and young people, and indeed the adult version of the questionnaire in children and young people, but we are aware that it happens a lot. Our decision support unit published a great piece of work looking at what tends to be used in NICE submissions and sort of commenting on that. And as I mentioned, there's a lot of work going on within and outside NICE to think about the best way to conduct evaluation study with children and young people. There's lots of challenges in valuing health in young people, not least sort of, for example, ethical considerations around conducting the time trade-off method that Koonal described when you're talking about death and giving up years of your life. So there's all sorts of challenges in developing a value set, and I think that's why it's taken such a long time to develop one for the youth version of the EQ-5D, and indeed for other generic measures of quality of life in children. I'll see if Koonal wants to add anything to that.
Yeah, so Sophie alluded to, we are supporting a valuation study to produce a value set and utility values for a version of the EQ-5D designed for use in younger populations. That study is being led by researchers at the University of Oxford. That isn't an indicator that we prefer or recommend the EQ-5D-Y instrument for that age group. It's one of many instruments, and NICE does accept for that age group, but we are working towards that. So at the moment, the focus is on the 5L value set, but we're hoping in the future to be able to make similar methods recommendations for measuring and valuing health-related quality of life in children and young people.
Great, thanks very much. I know that there are still questions that people have submitted, but I am afraid that we are pretty much out of time. So what we will do is we will review any of the questions we haven't been able to answer and see whether we need to update anything on our FAQs that you can find on the NICE website. But just to summarize, we are currently out for public consultation on NICE's proposals on adoption of the EQ-5D-5L value set, and that is open until 5 p.m. on the 27th of May. So anyone who would like to tell us in more detail what their thoughts are on the new value set and how NICE is proposing to implement it, please tell us your views and submit them via that consultation. Also to say, we have had a number of questions around implementation, timelines, and what it might mean for specific submissions. Just to remind people that we can't confirm the exact timings of implementation just yet, because we still have to consider what we get back from the public consultation and how we respond to that. But if a decision is made to adopt the 5L value set, especially for technology appraisal submissions, what will happen is that there will be a point in time in the future where the manual will be updated. And our usual process is that only for those topics with that start after that date would the new value set be used in those submissions. So I hope that at least clarifies some of the questions you have submitted around implementation. I would like to thank Koonal and Sophie for their excellent explanations today. I hope you have found today's session informative, and we look forward to hearing your views through the public consultation. Thank you very much, and the recording will also be available on YouTube if you want to watch any of it back. Thank you, and have a good rest of your day.